Welcome to another episode of Talking with Docs. I'm Dr. Paul Zalzal.
I'm Dr. Brad Wiening.
And I'm Dr. John Haverstock.
Welcome, Talking with Docs, a show where we talk with docs, and that's what we're doing right here.
We've got a guest doc talking about shoulders today. We're going to talk about shoulder dislocations, a very, very common problem. We're going to enlighten our viewers.
So I think, Dr. Haverstock, what we usually do is go through these, and you've done some of these with us before, thank you very much. We sort of go through what your symptoms would be when this happens, sort of how it happens, your symptoms, and then what happens when you go to seek medical attention. Then we talk about treatment, then we talk about long-term outcome. But the average viewer on social media has an attention span of 6 to 7 seconds, so you're going to have to be quick.
Me too.
All of us, for sure. So who gets it, John? Who dislocates their shoulder?
So usually it's young people, usually a sporting accident. Sometimes it's people, say they're going down the stairs and their hands on the railing and they fall and their arm kind of comes away from their body like this. So it's usually a fall or getting off balance with the arm in a throwing or an overhead position.
Okay, so it's usually some trauma that's required.
Yeah.
Now, if you're not planning on dislocating your shoulder, you should still pay attention in case you're at a house party or a get-together or a shopping mall on Black Friday. You might see a dislocated shoulder.
Interesting point. People used to think that Houdini dislocated his shoulder on purpose. But I looked into it, and actually he lied about that and said that that's what he did so that other people wouldn't figure out how he did it, and they thought, oh, he's just double jointed. We were not going to be able to do it, so he actually didn't tell people. So he actually did not do that.
He did not dislocate his shoulder.
Did not dislocate.
Did Mel Gibson do it?
I think he did in
And then
Lethal
reduced
Weapon,
it
I believe.
himself.
And
Popped it back in.
Yeah.
All
Okay, so how do they present?
So usually, for most people, they have this excruciating pain, and maybe it pops in on its own. Maybe a trainer on the edge of the field can pull it in, or a coach, which is a great idea, by the way. But sometimes people can't get it in. The muscles contract, they're in a lot of pain. They go to the emergency room, and the team there kind of gives them some sedation or manipulation and puts it in.
Okay.
Okay, so a great idea to try and reduce it if you know what you're doing. When a joint goes out of joint, and then putting it back in is called reducing it. So we reduce the joint means to put it back in joint, okay? And then the maneuver to put it back in is called a reduction maneuver. So if you know what you're doing and you've had some training, and you can try and then of course reduce, but usually getting medical help is the first thing we do.
That's right, someone who's trained.
Someone who's trained, okay. So that's happened. You're going to go to the emergency room, probably in this setting.
Definitely.
And then you will likely have it reduced in the emergency room after some sedation you mentioned.
That's right, yeah. So people feel a whole lot better once the shoulder's in place. And then having the arm in a sling for a week or two is probably the safest thing, just to give it some rest. This is the position where your arm feels much better, much stable. It's not going to dislocate when your hand's kind of right in front of your abdomen and your lap area. So you spend a week or two in a sling, probably have a checkup, probably have an x-ray right after to make sure there's nothing fractured or broken, and that's the initial start.
Okay.
Important distinction, the vast majority of shoulder dislocations are out the front, correct?
Definitely. 95% plus would be out the front, which means your arm is usually up and away from your body, and that's the most common by far.
And out the back, if I remember from residency, it was like seizures, electrocutions, it was all uncommon stuff.
Yeah, that's right.
So
okay.
Anterior dislocation is when it comes out the front. Posterior dislocation is when it goes out the back. Okay, so we're at the point now we've had it reduced in the emergency room. We're walking around with a sling for a couple of weeks.
Yeah. So usually you want to have a checkup. For young people, they tend to bounce back pretty quickly. And young for a shoulder dislocation is, say, under 30 type thing. Over 35, 45, the chance of having other additional injuries gets quite a lot higher. So it's easier to tear a tendon or have a fracture of the bone or a nerve injury. And so that's why you want to have a checkup to make sure none of those things have happened. And then you're probably going to be referred to a physiotherapist to have some education and get the shoulder moving in a safe way.
Okay, so over 30, 35, you're saying they've probably done more damage?
It's a subjective. It's, I would say over 40, 45, the average shoulder dislocation is, around 20 or under.
Okay. So then you go to a physiotherapist, and
Yeah.
you're going to get it rehabilitated, or a physical therapist if you're in USA.
Yes.
And then you will get it rehabilitated.
Absolutely.
And then, so then the path after that, John, for the younger people versus the older people, what happens to them? So say I'm 2 weeks, I feel pretty good, I'm 20 years old, I'm a snowboarder, I'm going back on the slopes?
Yeah, You certainly can. I think when you see a professional, usually a surgeon, they'll kind of tell you what are your risks for redislocation. Being kind of a double jointed person, stretchy kind of joints, if your elbows hyperextend or your thumb can touch your forearm or your pinky bends way back, these are some of the things that can increase your risk of dislocation. Being younger, say under 18, participating in contact sports, are other things that we know that will increase the risk of further dislocation.
I've been using the cutoff as about 40. If you're under 40, your chance of redislocation is a little bit higher than if you're over 40. It's one of the only times in life where it's good to be older.
Yeah, that's a good way to think about it.
And so, say you go out and you fall again, and
Yeah.
you dislocate again, and then do you just do the same thing? You go to ER, you pump it back in, and then you just keep doing it over and over again? That seems like not the best plan.
So a lot of people will have a second dislocation. We think it's probably about half the people that have a dislocation will have a second dislocation. And once you have a second dislocation, we think it's kind of more likely to persist over the years.
Okay.
Okay, so let's say you're the type of person that has now had it dislocated, and then it starts dislocating again, maybe with a little bit less trauma the second time and less trauma the third time. When do you decide, okay, now it's time to do something surgical about this problem?
So from a surgeon perspective, there's a camp where some surgeons say we should do a surgery after one dislocation because then we're going to avoid another.
In young people?
In young people. And then there's a camp that says maybe we should wait until they have that second dislocation and we know they're at a higher propensity to have more dislocations further.
That's the camp I went to.
Yeah.
I didn't go to either of those kinds of camps growing up.
So
you missed out.
It sounds like it.
So mostly it's the patient saying, listen, this is bothersome for me. I can't trust my shoulder. I can't do the things that I want to. Some people start having dislocations when they put their hand under the pillow at night, or if they reach into the back seat of the car. And when you can't trust your shoulder, it changes the way you work and you live, and that's when people often want to have surgery.
And so that decision is made, A, by the number of times they've dislocated, their intolerance for the dislocations, and then do you order any special tests? Obviously we got an x-ray to start, and usually the x-ray is going to look mostly normal. Are there any special tests?
Yeah, so an MRI is probably like the best test. And what that shows us is it shows us the cartilage and the labrum, and it shows us in 3 dimensions the shape of both of the bones, because sometimes after repetitive dislocations you can miss part of the socket. Imagine the socket's a little bit like a golf tee, it's that kind of shape, and the ball can actually get a dent in it. So if you get a dent in your ball and you're missing the edge of the golf tee or socket, it's going to be very unstable.
Long day on the links with that happening for sure.
Okay, so for those of you that have stuck it out this long into the video, we're going to reward you with an x-ray, okay? So here is an x-ray of a shoulder. Can you just talk to like a few of the salient features in this x-ray?
Yeah, so we're looking at here at an x-ray, and what you're seeing is the ball. Obviously it looks semicircular, and the socket are not overlapping. So this is a picture of it dislocated, okay? And then we're going to put another image up of what the shoulder looks like in
here
joint.
It is, popped back in joint.
So if you're the type that's had a few dislocations, you want to consider surgery. We've got a really nice MRI image, and what that shows is it's looking at kind of the shoulder from the bottom. So you see the shoulder socket is kind of like a golf tee again, okay? And then you can see the big ball on top of that. And then we've got a little arrow just where this golf tee is separated. So the labrum is this bit of cartilage that separates, and once it separates, it doesn't really heal in the correct spot, and that's why people continue to have dislocations, because the bumper isn't there to prevent the ball from slipping out.
So it's more commonly a soft tissue problem than a bony problem.
That's correct,
Yeah.
but we
That
can
can be
get
similar.
chips of bones, yeah.
Sure.
Okay, so here we are. You've dislocated your shoulder. Now you know that happened with usually some trauma. If you're younger, there's a chance it's going to happen again. If you're older, there's less of a chance it happens again. However, you may have damaged some of the soft tissues around it. You've had it reduced in the emergency room. You were in a sling for a couple of weeks.
Mm-hmm.
Then you did some physiotherapy to get it going again. If you're unfortunate and you're a recurrent dislocator, then you might have to have some surgery to stabilize it. So when can I go back to, sports or whatever I was doing?
Yeah, I think that the safe average answer would be after surgery. Is that what we're talking after
Sure.
surgery? would be about 6 months after your surgery. I think you can hustle it if you've got a professional team and it's your job to maybe get back, but we do think it takes around 3 months for those cartilage to heal, and then we've got to get our shoulders strong again. We've got to do our sports specifics training, and the proprioception is that mind-body awareness. Where can I move and how can I be confident?
Generally speaking, would you say this is a successful operation, like in the realm of surgical procedures?
Yeah, it's very successful. For our average surgery, we do it arthroscopic, so the keyhole, usually 3 or 4 small incisions, each about 1 centimeter, 1, 2, 3. And what we do is we pull that torn labrum, that cartilage bumper, and we put it back on the edge of the socket where it belongs. We hold it in place with usually 3 stitches, and it's got a success rate of around 85 to 95%, depending on how you look at it, of not having another dislocation.
Sure.
Okay, that's a great summary. It was a little longer than 6 to 7 seconds, but I think it was worth it, especially if you stuck around to see the images at the end.
Yeah, thanks for hanging in. So if you've had a shoulder dislocation, now you know kind of what to do, what your options are, and that there are options. It's nice for people that think, I just don't want to live with my shoulder popping out every time I take a nap.
Definitely.
So if you like this video, please like it, subscribe to our channel.
Dr. Haverstock, thank you very much for
Thanks for
taking
having
time
me.
out. And remember, you are in charge of your own health.
We'll see you next time.
We're the 3 best friends.